Hello, everybody. Thank you for joining us today. My name is Fida Pineda, and I will be assisting with today's webinar along with Dr. Kevin Lombardi. Today, we will be presenting a webinar on leveraging telehealth to address tobacco cessation, and this is brought to you by the National Center for Health and Public Housing. Before we continue, this is just some housekeeping items that we'd like to remind all participants about. All participants are muted upon entry. Please make sure that you engage in the chat if you have any questions, any comments, or any promising practices that you would also like to share with us today. Please raise your hand if you would like your line to be unmuted. This meeting is also being recorded, and the slides and the recorded link for today's session will be sent to you all via email after today's session. We would also like to learn more about you, the audience who is joining us today. So also feel free to share with us via the chat, which I'm going to enable right now. And share with us your title, your name, your title, and the organization that you're joining us from. We will be very glad to know more about you. So here we have some background information about NCHPH. The mission of NCHPH is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration and is also a national training technical assistance partner that is 100% financed by this grant. And the information presented today are those of the author only. Thank you so much. We can see that we have some participants that are providing their information here. Thank you for joining and welcome. And also some information about today's speakers. My name is Fida Pineda Sandoval, and I am the manager of TTA here at NCHPH, and I will be helping facilitate today's webinar. And Kevin, would you like to provide your introduction?
Hi, everyone. Kevin Lombardi, Dr. Lombardi. I am an epidemiologist and physician. I currently serve as the manager of health policy, research, and health promotion here at NCHPH. Prior to this position, I served as the executive director of an international public health nonprofit, Your Story International, and performed my residency in internal medicine at the Danville Regional Medical Center. I've also served in various health consulting roles, including for Hanover Research. So I hope to leverage all of those in our session today.
Thank you so much, Kevin. And now we will get started with the rest of the presentation today.
Okay, so we just got some introductory slides here, folks. Most of my teaching is about the SDOH. This isn't a very SDOH heavy subject, but the framework is integrated into most of what we're going to be doing. So I always make sure I put these resources up for those of you who want to know more about the SDOH and how the diverse aspects of patients' lives affect their health and healthcare. So there's a link on the bottom left there. Next, please. And for those of you who have more of an academic interest in the SDOH, I recommend picking this up. It's the WHO conceptual framework. It walks through the academic and social explanation of how the SDOH comes from our understanding of human rights, our policy choices, and our more equitable outcomes. And the more equitable outcomes are what you all do at your health centers. So thank you for your service. And if you'd like to pick that up, I'd recommend reading it. It's great with your coffee in the morning. Next, please. A little bit about how I like to do my sessions here. The session is designed to elicit discussion and to elicit meditation on the diverse aspects that affect these very important social topics. There will be discussion questions that are integrated into the session based on some case studies that are written from real patients I've seen. I encourage all of you to connect in the chat, and we'll be trying to make sure our questions are as cooperative as possible, because one of the great things about these sessions is your colleagues are also on the line. They're They're working in diverse places across the country, and trust and believe there's someone who's also on this session that could help you and vice versa. So this is an important aspect of interdisciplinary support, which from my experience is very important with continuing to improve your practice, continuing to improve your health center, and thinking of new and innovative ideas to make everyone's lives healthier, easier, and more efficient. And assistance. These are designed as consulting documents. You guys will all get the slides on the bottom left. I have links. All of the research has been peer reviewed by me. Some of the research has been done by me. You guys have first access to all the new stuff. And for all the toolkits and protocols that are put in here, they've gone through a detailed medical review by myself and colleagues. Next slide, please. And I just did that. So let's go to the next one too. So we're talking about three main things today, as in the confluence being leveraging telehealth for tobacco use disorder and nicotine use disorder. To cut down on my use of slashes, I'll be using the terms kind of interchangeably, but we are talking about both. We're talking talking about both tobacco products, cigarettes, and cigar use, cigarillos, and so forth, and also vaping products as well. These have similar health issues and consequences in terms of cardiovascular disease, mental health, and so forth. And also, because they have the same addictive iteology, they're very similar in terms of patient response. There are, of course, differences, but for the purposes of this webinar, we'll be kind of focusing on all of them broadly. So our goal here is really to garner an understanding of how to best utilize telehealth for these conditions, and we'll be doing three main things. We're reviewing some recent data that gives insight into TUD, NUD use in FQHC patients, and a special look at our HUD-assisted and public housing patients. And I do that because we are the National Center for Public Housing, but also the public housing population gives us a good insight into a lot of other disadvantaged populations, African Americans, Latinos, and so forth, how they experience this because they are disproportionately included in this group. So we'll be analyzing clinical cases, outlining the use of telehealth in NUD and TUD, and some best practices regarding telehealth modality use, and really the concept, how you're conceptualizing the use of telehealth as an extension of what your providers are doing in the in-person setting. Next slide, please. So let's start with a couple of introductory questions. I love when the chat is just popping. So if you guys could please answer one or all of these questions. At the very least, I'd love to know about what you do, where you're from. That tells me a lot about how I can guide what I'm talking about. If I'm seeing more rural or more urban, so on and so forth. But what institution are you joining us from? What are your roles and professional responsibilities? And if you've got something you can pop in about how your institution serves patients with NUD, TUD, please do it. So let's take a minute and do that.
So while we wait for the responses, we do have a question about the slides. And yes, they will be shared after today's session.
And please be liberal with sharing them. The government funds us to create these for you. Please send them to colleagues and so forth, resources, contact me if you need any extra information or something interests you. We work for you guys.
Yep.
Okay, so we got some respiratory therapists, great. Health educators, oh, what a great group. Prevention, tobacco control. We've got some folks from Michigan. We've got Ohio, Louisiana, service coordinators. What a diverse group. This is why I love these sessions. We get people from all necks of the wood. Fabulous. So let's go on to our next, and please continue to type if you could. Let's start by, I like to teach these sessions like I perform my clinical duties. And the start is with the data. We will then connect the data to the patients and then to the promising practices. But it's really important for us to understand for our patients, FQHC patients, public housing HUD-assisted patients, how are they experiencing this? And what are we dealing with as sort of baseline understandings of how this is manifesting epidemiologically in our communities? So here we go. Next slide, please. This is a recent study by my team. What we essentially did is we took something called the Health Center Patient Survey, which is a survey that HRSA does of all of the FQHCs, or a large sample of them. And it gives us insight into the whole population of FQHC patients. Luckily, because they ask questions on public housing, HUD-assisted status, and so forth, we were able to do a comprehensive recode to look at these as different populations. So I know this is a bit busy here, but we're going to break this down and understand the data points and how the data points are actionable for us in our practice, and especially in program development and social support. Next, please. So our p-values are our main way of looking at statistical significance here. I'll only be focusing on things that are 0.05 or less. Next slide, please. And here are our patient populations. We have our FQHC patients, everyone who lives in private housing. Those who are HUD-assisted in the green is our first comparison group. Those who are public housing only are a second. So let's look at how these patients are different and how they're experiencing TUD, NUD, and tobacco cessation. Next, please. First data point, current smokers, and that's people who have used it within the last 30 days and identify as a smoker. Next slide. That's our data point right there. Next slide. So here's an infographic that looks at it more. Yeah, back feeding. The one with the images. Yes, this one. Thank you. And are you a current smoker of cigarettes, cigars, or similar products? So with our all FQHC patients, the whole group, 20.3 identify as a current smoker. But when we look at our HUD-assisted in public housing, we notice that that's a fair amount higher at 31.4% and 34%. These are populations that are more likely to be smokers, they're more likely to smoke more. And let's see what the rest of the data says. Next, please. Plans to quit. This one's really important because it's part of your tobacco cessation counseling. It's part of how you start talking to the patients, and it tells you a lot about where the patient is in the decision-making continuum when they decide to quit. Plans in the future to quit smoking for good. And that's let's go to the next slide and look at that data point. Do you currently have plans to quit tobacco use for good? Now, the good thing here is if we look at our FQHC patients, a lot of them are currently thinking about this right now. And that's great news. And 77.1 is a big number. It's bigger than I expected. And it's certainly bigger than I've experienced in the clinical domain in my exam room. What's interesting to see here is the public housing patients. They're even more likely to want to quit smoking than the people who live in private housing. And we don't know why that is, but it's important to notice that these are folks that may be more receptive to tobacco use counseling or may be more likely to want to use that service. Next slide, please. Desire to quit smoking in the last 12 months. Now, we just looked at it in 30 days. Let's see who's thought about this in the last year. Next. These are big numbers. Take a look at this. In the past 12 months, have you had the desire to quit using tobacco products? For all FQHC patients, it's similar to in the past 30 days, 75.9. But when we see HUD-assisted patients, it's close to 100%. And I didn't put the public housing in here because of the sample size, the p-value wasn't big enough, but it's similar. And we can make some assumptions that it's likely similar as well. But what this tells us is the HUD-assisted and public housing population, they're more likely to smoke, they're more likely to want to quit smoking, And this tells us a lot about how receptive they are to tobacco use counseling. Now, let's take this and bridge this data onto the clinical realm. Next slide, please. One more data point for us. And I put in a lot of extra stuff for those of you who are data nerds like me, who want to look at tables. Here they are. We'll just go through this. Next slide. This is some data on tobacco use disorder counseling and FQHCs. Data tells us that you guys do very good with identifying patients and counseling them. So thank you for your service. And here's some affirmation for you. Next slide. And the next one, please. And the next one. Okay. Actually, could you go back one just before we bridge over to the clinical realm? Telehealth use is very popular at FQHCs. A lot of you got most of the FQHCs that I've spoken to no longer have the issue of not having the equipment to use the modality. They have too much of it via COVID, granting, and so forth. And if we look at where this is used, telehealth is being primarily used in these main areas. Mental health and substance use disorder, and that includes nicotine use disorder, is an area where we're seeing a lot of growth. And the reason is because it works. With these addictive disorders, just talking to someone, let me tell you from my own experience, just talking to someone in the exam room every 6 months does not cut it. You've got to make these messages over and over and over again. Being able to have access to telehealth for tobacco use disorder and for other substance use disorder does a couple things for you. One, you're able to continue that conversation and reinforce the points. And with addiction, addiction lies to your brain. Tobacco lies to your brain. In order to re-engineer the thought processes, people need to be able to talk to someone they trust in an extended way. And that's with other addictive disorders too. Data shows us that alcohol and other substances use the same neural pathways that tobacco does in terms of behavioral reinforcing in both the temporal and the frontal lobes. So this is where FQHCs are using the stuff, and it's because it works here. Next slide, please. So let's bridge this over to the clinical realm. And I'm going to go over a case, and I'm going to have some questions for you guys. And I want to think about this as deeply as we can. When we're in the exam room or we're dealing with a patient that we're counseling, we're only seeing pieces of it. Here I designed this case so we're seeing the whole patient experience, but also we have time to look through the details. I can't tell you, when I have 15 minutes with a patient and then I'm writing my notes, I usually miss details because I'm going through a quick patient interview. I'm collecting as much as I can, and sometimes I have to go back to my notes 2 or 3 times to make sure I've gotten everything in there. It's hard to keep up with the details. This is an opportunity for us to go through the details and really understand them. And that's how you increase clinical acumen. And for those who aren't in the clinical sphere, understanding what goes on in the exam room is supportive to your profession as well, because you are in the continuum. The more you know about we do, the more we know about you do, what you do, the better we all get at taking care of these folks. So I'm going to read the case study, and we're going to go through it. So we have Mr. Jones, a 57-year-old man who presents for wellness exam. He has a past medical history of type 2 diabetes mellitus and hypertension. The patient has a behavioral health history of major depressive disorder, generalized anxiety disorder, and tobacco use disorder. And when you're looking at his 2018 notes, it says he's been in remission for a year. Good for him. Now let's see where we're going. Mr. Jones is a combat veteran. Your health center has a large veteran population and is in the suburban area of a medium-sized city. Mr. Jones identifies as African American. The patient undergoes standard intake with your nurse assistant and does a vitals and STO age screener, as many of you do at your centers as sort of a protocol, practice protocol. Results are as follows. Well, it looks like we have high blood pressure, 170/98. His heart's going pretty quick too, 92, and respirations in the normal range at 18. Okay, you're the provider looking at the medical records. What do you have here? A review of Mr. Jones' medical records indicates the following. And okay, in 2018, his blood pressure was a little elevated, but much better. 138/98. Heart rate was 60. Respiration was 18. Okay. His H1 HbA1c is 7.0, negative on the drug screen, and we see he takes metformin, a loop diuretic, and an SSRI medication. So he takes a diabetes medication, he takes a high blood pressure medication, and he takes a depression medication. Okay, that tells us a lot about the patient. Next exam. Oh, next slide, please. So this, for those of you who don't use an SDOH screen in your clinical practice in the outpatient setting, highly recommend integrating one into your practice and feel free to add questions or add things that are important to your social support of your patients. I'll get a little bit more. This is the WellRx screener. It is open and free for use. There's a link to the resource in the bottom left. If you're interested in using it, integrating into your practice, please feel free to contact me. But we got this SDOH screen. It's in the spirit of the Prepare screen. So in the past 2 months, did you skip meals? We see yes. Are you homeless or worried that you might be in the future? Yes. Do you have trouble paying for your utilities? Yes. Do you have trouble finding or paying for a ride? Yes. Daycare? No. Next slide, please. Are you unemployed or without regular income? Yes. Okay, so we're getting a detailed picture of this guy's life now. Do you need help finding a better job? Yes. Education? No, he doesn't want any help getting education. Are you concerned about someone in your house using drugs or alcohol? Yes. Do you feel unsafe? No. Is anyone in your home threatening or abusing you? No. Okay. Let's see what we can do with this. Next slide. Okay, so you're in the exam room with Mr. Jones. He's treated by his provider, who is also a combat veteran. Upon physical examination, Mr. Jones is noted to be withdrawn and to exhibit closed body language. You all know how this person is. Someone who doesn't look very happy to be in the room or to be interacting with you. His responses are terse, and he seems irritated. His physical examination is positive for 1+ pitting edema, so he's got swollen feet. He's got darkened skin around his neck and groin area. New results are positive for a hemoglobin A1c of 8.2, which is higher than his 2018 7.0. Okay. When questioned regarding the results of his SDOH screener, Mr. Jones reveals the following. Mr. Jones works as a construction foreman until 6 months ago, until he was laid off. His unemployment ran out 3 months ago. He's behind on his utilities and his car is not operable. He previously abstained from cigarette use, but now smokes approximately 1.5 pack per day. He's single with no family, and he has been taking a half dose of his other prescription meds, blood pressure, depression, and diabetes, because he can't afford the medication. This is a very common story. So you as the provider asked if he's interested in, among other things, of course, of stopping tobacco use, but he avoids the question. When questioned again, he notes that he tried several times lately, but always ends up smoking again. He agrees to an initial trial of nicotine gun and also notes that he prefers to deal with his private life by himself. And this is when you ask him about continuity of care. He's not really happy about the idea of continuity of care. When asked why, he notes that in the past he's had difficulty connecting with his providers and that he's felt judged. Now, as we're talking about Mr. Jones, think about why someone like him would feel like that. Now let's go to some questions. Next, please. Okay, case study. What is your assessment of Mr. Jones' clinical condition, and how is tobacco use impacting it? This can be as detailed and as simple as you want it to be, and the simple ones usually hit. I'll say that. The other one is, how could a patient like Mr. Jones be encouraged to seek supportive services? Now, Fide, we are going to take a few minutes here. Please, please, please put your response in the chat, and then we will reflect on those and go through the case and connect this more deeply to telehealth and tobacco use. And Fide, could you cycle through the slides? I'm going to put the questions right in the chat so folks can see.
Okay, perfect. Yeah. So let me do that. And then also just a reminder to the audience that you're also more than welcome to raise your hand if you like for your line to be unmuted, and provide your responses verbally.
So we've got some thoughts about the smoking and hypertension already. What do we think about the other medical conditions as well? The depression here. Yeah, he's a combat veteran. Yeah, we're getting some really good insight here into the social situation. I love this. I must say, as a physician, having access to the opinions of the people in these sessions is very helpful in terms of understanding social support. You all always teach me something. So go away, do your thing. This is a complex patient with a detailed social history, and it's very difficult to digest these, especially when you're doing it over in 15 minutes. Okay, we're going to stop. I'm going to let Fide read through some of the responses and ask folks if they want to share. And then I am going to do a quick run through.
Okay. All right. Well, I'm going to start with the first response that we have in the chat by Candace. Smoking is exacerbating his hypertension. Would you like to elaborate a little bit more on that, Candace? I'm going to unmute your line. And then if not, it's okay. We also understand you maybe work.
Yeah, no worries if you can't share, but we will ask. Ms. Bustamante, good to see you. Do you have anything you'd like to share?
Hi there. Yeah, definitely the smoking is going to increase his blood pressure. And, you know, due to all the social situations that he's going through and the social aspects impacting his clinical situation, I think someone else mentioned it's just going to be another vicious cycle until he gets help for all the multi-factors affecting him.
Yeah, so that's like a very important point here, is this is a guy who already has hypertension, right? He's stressed out, he's not taking his medication, so it's already going to get worse, predictably. But when you have smoking added to it, it just makes everything much more complicated. It independently affects the hypertension, and you're 100% right about that. But it also increases anxiety and depression, which is possibly going to make the stress worse. So we have it's sort of a positive feedback loop that's working in a negative way. So thank you for sharing that. Candace, can you tell us where you're joining us from and what you do?
Yeah. I am the clinical education coordinator and program supervisor for the Courage to Quit program at Holy Cross Health in Fort Lauderdale.
Well, thank you so much for your service, and thanks for sharing with us.
Of course. Thank you.
Fide, I think we got time for two more.
Yeah, perfect. All right, so next we have a response by Princess Perez. Ms. Jones' financial situation perpetuates his addiction and other conditions. He does not have adequate medical care for his conditions. It's a cycle. That's correct. But would you like to elaborate a little bit more on that, Ms. Perez? I'm going to also mute your line.
Yes, hi, good afternoon. Let me see if I can get the camera on here. Or maybe you can't see. So yeah,
we believe you.
Okay, great. Yes. So this particular case is a sad case, but it is actually a very common situation where you have a person who's mentally ill, physically ill, cannot have access to taking care of the mental health component, and doesn't have access to adequate care for the physical component, and both of those things feed off of each other. And so he is actually trying to self-medicate through the nicotine because he doesn't have adequate medication. So he's taking half of his recommended dosage for his depression or other medications, and it becomes a vicious cycle, and it's hard to break, and it requires a lot of assistance, not only on the physical, on the mental, but also with addiction cessation. He needs to understand that his condition is not going to get better. It's actually going to worsen and continue to worsen if he continues to smoke. And if he's in such a financial rut, smoking is very expensive. So it has to be, I guess, taught to him in a whole different, basically on different levels. But it will take time and a big effort from his medical team as well as himself.
And Ms. Perez, where are you joining us from, and what do you do?
Hi, Kevin. Yes, I'm from the Florida Department of Health in Miami-Dade, and I am a senior health educator for the Tobacco Prevention and Control Program.
Well, I can hear the motivational interviewing coming through your response, and I love it. And this gets a lot to how we talk to patients like this. In many cases, they are self-medicating. People with schizophrenia, depression, anxiety are much more likely to be users of tobacco products. And there's a reason, because there's a real pharmacological thing that they are searching for with those substances. The unfortunate thing is that it tends to only help a little bit in the long run and hurt a lot in the short run, and hurt a lot in the long run. So this is a patient who needs some targeted motivational intervention, in particular, helping him to understand where this tobacco is affecting his decision-making process and his current condition. So thank you so much for giving those details to me, and for your service as well.
Thank you.
All right, Fide, I think we can do one more, and I'm loving these responses.
Yeah, thank you so much. Next we have Debra Net. Due to not being able to afford his medications or correct food, his diabetes is not stable, and he has his depression but isn't doing anything about it. Debra, I'm going to also unmute your line.
And I think is it Deborah?
Or Deborah. My apologies if I mispronounce your names.
We do it to you all the time, Fide, no worries.
I know, always happens.
Deborah, are you able to share with us some insight into your response?
Well, she typed in her response, so she may
Read
not
that,
be able.
please. Thank you, Deborah. Thank you. We'll have Fide narrate for you.
She said might benefit from the use of a care case manager or health coach to be able to build a rapport with him and connect with him more frequently than being seen in an office facility. They would be able to offer assistance for his food insecurity and utility issues along with smoking cessation. Using motivational interviewing can get him to come up with the reasons he wants to quit.
So I think Deborah saw my slides beforehand, but this is a very good point. And we're going to start now by focusing on the continuum of care, because the exam room is just one part of the process. Next slide, please.
Okay, and also
responses and for your detailed analysis. So let's just look pick out all the clinical pearls here. So we have a patient with some very serious chronic medical conditions and behavioral health conditions. We have type 2 diabetes mellitus, we have hypertension, and we have a behavioral health history of major depressive disorder and generalized anxiety. He's diagnosed with TUD, and he's previously been in remission. So we know that this is a person who has gone through the process before, has struggled with it, and has had some success. At this point, we don't know if he's restarted use, though. So another important thing is he's a combat veteran. So when considering the behavioral health history of these individuals, and their counseling and what sort of services they need. This is really important. When I think of combat veterans and giving them appropriate care, sometimes I think of it as sort of like a cultural competency issue. They are well served by people who understand the military service and understand the struggles of military service. And another great reason to have veterans on your staff and working in your clinical staff is because it means a lot to these patients to be able to talk to folks who have had similar experiences, or is from that same culture, let's call it. So Mr. Jones also notes that he identifies as an African American. So let's look at our blood pressure here. And yeah, you guys are right on. This is a patient who has higher blood pressure, heart rate's high, and we're trying to figure out why. You see he takes medications for all three of these issues, and his A1C was previously elevated, but not terrible. Next slide, please. Next, you can go through the screen to where I have the next step highlighted. Okay, so again, combat veteran, he is withdrawn. He does not seem to want to be here or to be talking to you. He's terse and he seems irritated. This can often be for someone who's a regular smoker, just being in the office for 2 hours and not being able to smoke will get them irritated. They also sometimes aren't really open to being spoken to about this stuff, and they're expecting it. So we look at him though, and we see some other stuff that's kind of concerning for his chronic conditions. The 1+ pitting edema, well, when I see that on a patient with serious hypertension who's experiencing blood pressure the way he is, I start to get worried about congestive heart failure. And when I see darkened skin around his neck and groin area, I start to worry about exacerbation of his type 2 diabetes. And lo and behold, we have an A1C of 8.2. So this is a patient whose diabetes is getting worse. And you keep an eye on the neck and groin area because they will have darkened skin there. And especially when you have a patient who's worsening quickly like that, that's a great indication of that. It's something you can describe to the patient too that they will understand from their physical exam. And because a lot of times they've noticed, like, it's starting getting darker there. Was it a sunburn? Is it whatever? Being able to talk about that with them in the interview is a great way to intervene. So the social history is complex, and there's just a lot going on in this guy's life right now. He was laid off, and his unemployment insurance ran out 3 months ago. I didn't add this, but this is a guy who comes from the Midwest, and guess what? It's cold up there in the winter, and a lot of construction workers smoke to keep warm. He's behind on his utilities. He's previously abstained from cigarette use, but now uses approximately a half pack a day, which is a big investment for this guy. Single, without family, lacking social support, and has been taking half doses of his medication because he's running out. Okay, so let's try to take this patient into the telehealth and continuity of care realm. Next. First, some details on mental health. This is a patient who has mental health issues, and for those of you who work in this field, this is not a surprise to you, but it's important to focus on. Folks that experience depression, anxiety, schizophrenia, other mental health conditions. Those conditions are independent risk factors for cigarette use. Particularly in schizophrenia, they have some of the highest rates of tobacco use disorder. And that's because it's a way of self-medicating for them. And it's an ineffective way, but it's something that's readily available and it's something they're exposed to. It's very easy for these folks to get addicted. So things to keep in mind is that when you're treating someone for tobacco use disorder, this needs to be integrated into a larger continuum of care regarding mental health use. And the benefits of telehealth and the benefits of being able to link with an individual like this is you can also string that over to behavioral health treatment as well. So our current patient would be well served by using this modality for two things, both his tobacco use disorder and for his behavioral health conditions. Next, please. Now, when I got started, telehealth was, it wasn't covered by insurance very often. It wasn't used very often. We'd use it in like extreme cases where we really needed to get someone. The modality was not well defined or well used. That has changed substantially since I started practicing. And telehealth and the advantages of having telehealth modalities in your facility telehealth applications and services is it is extend the continuity of care with the patient significantly. This is in particular for patients who don't like going in or who live in rural areas. If they have a broadband connection, they have care. And for health centers, it's a great opportunity for you to use your reach to the patient, use multi-channel marketing to get them onto your telehealth platforms and get folks that may be disinclined from getting care to use care. But how are we conceptualizing this as providers? It's a tool for us in our toolbox, and it's becoming a much more used tool by providers like myself and providers who are trained in the traditional clinical way. It gives us a way to extend to the patient, to understand the patient. And let me tell you, when you come into an exam room, if anyone's ever read Foucault's The Clinic, it's a examination of the power dynamics of the clinical realm. When people walk into hospitals, it's scary because everything in the hospital is designed for the ease and the use of the provider, and that communicates a certain power. For folks who are experiencing tobacco use disorder or experiencing behavioral health issues, being able to do things in the comfort of their own home can make them more inclined to get treatment, and particularly for more as people who have those conditions or just naturally inclined to be more private or to not like the clinic for one reason or another. It allows you to it allows for a more diverse catchment base of patients is what it allows. Next slide, please. And the shift to hybrid care. When I first started, there was in-person and there was this telehealth was kind of thing that happened every so often. And that bubble got bigger and bigger until COVID really extended that significantly. And now as providers, we have the opportunity to have hybrid care networks and be able to see patients regardless of their physical location. And when we're talking about something like substance use disorder, tobacco use disorder, nicotine use disorder, this is extremely important because the patient needs multiple touch points for reminders and reinforcement. So if we have a patient like Mr. Jones, one clinic appointment is just not going to do it. It rarely does. And what he needs is continuity of care. So let's get into that and how that would look like. Next slide, please. For those of you who use telehealth, a little consulting public notification here. What I hear very often from the FQHCs that I advise is that they're having issues getting people to use the service, or they think it's underutilized. And when you are starting a telehealth service, expanding a telehealth service, if you have an existing one that you feel is underutilized, multi-channel marketing is a very important thing to consider. And it's not just sending things on a patient platform. It's text messages, it's emails, it's mailings if you can do them. It's going to be different what your community is, but you need to let people know that these services are available, and you need to market them too. And things to focus on. One, emphasize convenience. What kind of communication channels reach the patients in your community? What kind of partnerships can be leveraged to reach patients? Emphasize to the patients that this is a great way to get convenient care. Reduce stigma. Stigma continues to serve as a major barrier to service, in particular to things like this. Tobacco use disorder and substance use disorder are often in the same bundle. Reducing the stigma, making it seem as normal as possible, and telling them that it is normal. Getting telehealth is normal, and getting care for these things is normal. De-emphasize reduce the stigma at every opportunity you can, because it's been reinforced by society for a very long time. And increase access to care, the obvious thing. Making sure you give everyone the notification and making sure they know that this is there to increase access to care. So next slide, please. So let's get to continuity of care. Mr. Jones is contacted by a staff member that works for your facility. He initially refuses assistance. The CHW offers the following resources, which lead Mr. Jones to agreeing to an initial consultation. One, Mr. Jones didn't want to get in. Consultation via telehealth is what he preferred. Two, you happen to have a community-based African-American veteran as a CHW. when you're seeing these patients, when you have two people where there's just such a link like this, it's a great opportunity to get folks that are similar, that can support each other. And it's very important to have as much reflection of the community in your staff as possible. CHWs are a really important piece of that. Having CHWs that know your community, that know the cultures and types of people in your community, that are familiar with how to communicate them, is really important. But also having members of those communities in the chair is just as important. It allows folks that may have been disinclined to get care because they feel like there's someone there who understands them, and that's very important. Mr. Jones meets the CHW via the facility telehealth mobile application. In the beginning of his appointment, he has a short introductory session with his CHW. They get to know each other and so forth. He uses the following techniques to make sure he's comfortable during the visit. Next slide, please. Now, I'll go through these quickly because I know most of you are active in the field, but it's really important to emphasize these within the continuum. Active listening, fully comprehending the client, giving them time to speak, paying attention to their verbal and nonverbal clues, including their emotional state, is incredibly important for you understanding the patient and being able to guide them in the right direction. Not paying attention to those cues, verbal and nonverbal, is often one of the easiest ways to lose a patient's attention and to lose their commitment to the shared goals. Very important. Adaptive questioning. And this is kind of fun. I always loved adaptive questioning because it allows you to really understand the patient and to be creative with the process within your practice continuum. And starting with general questions and then becoming more specific as you find things that are important. And an important thing to remember about this is you're really guiding the patient in a certain area. You don't want to just tag people right down and ask them all the criteria questions directly. It's intimidating. It's not fun. It feels like an interview. You want this to feel as natural as possible, but balancing that with staying focused on the questions. Guide the patient towards the information you want to get. Ask the questions in a respectful and conversational way. You'll get way more information, you'll get better information. And you will build rapport. And that's an important thing here when we're talking about a CHW, seeing a patient long-term. And the nonverbal communication. Do you want to talk to me when I'm like this or when I'm like this? Like, this is much better because I seem open and like I'm going to listen to you. If I'm going like this, I'm not. Be very mindful of both your nonverbal communication and the patient's, because again, easy way to lose connection to the patient, make them seem you're uninterested. And it's important data. It tells you about how the patient feels about sitting down with you in the first place. First thing you should look at. Next slide, please. Empathy, validation, and reassurance. A lot of reasons why we're doing telehealth in the first place with people is they didn't feel comfortable coming into an in-person visit. And that is a lot more common than people make it seem. So validating a patient's experience and their emotions is important. People are used to getting shamed for their tobacco use. But as some of our answers to the last question made it clear, I can't remember who, but there was some details on, maybe it was Ms. Perez, the details on the patient's life and how oftentimes people self-medicate with these things. Yes, and there are 1,000 different experiences of people who use tobacco in similar ways. And when they are struggling and the tobacco is something that they feel gives them a little respite, shaming them about it in any way really invalidates the experience and frankly can kind of piss them off a little bit. Reassuring the patient as much as possible that their actions and their emotions are reasonable and you are there as a team member to help them build a better and more adaptive life. Well, people like that. Folks like being coached, and they like being coached by people who care about them. So take that perspective when you're dealing with the patients. Partnering and summarization, again, with the coaching. You are on a team and you are going to, you know, the big game is starting to use an intervention. It's thinking through the process. These are all different parts of the fall schedule. And making a patient feel that you are partnering and with them is really important. And it's not something you just say like, hey, we're partners. It's something that people understand you're a partner when you act like a partner, and verbally caring about what the patient's doing, empathizing and validating their experience, and staying focused on the goals is how you make people feel that way. And transitions and empowerment. Take every opportunity you can to encourage your patient. Every opportunity you can. Next, please. All right, so I put this in because it's always good to redo your SGOH screener when you're starting with a new CHW, even if it's been done in the clinical realm, to compare the results. We see here it's the same. Next, you can go to the next text slide, please. Okay, so we have this patient. He's sitting down with the CHW. He's gone through a couple of exams. What are we focusing on? So the CHW is, at this center, is a general use CHW who's trained in tobacco cessation counseling. So they provide tobacco cessation counseling, but are also able to link the patient to a variety of other services. This is the system that I recommend for those of you who are using CHWs, other social support professionals to do this, is to integrate it into a broader social support system. So we have our SGOH screener. It told us a lot about what this patient needed. So the CHW and Mr. Jones talk about these things. Education, access, and quality. No resources identified. Healthcare access. And these are some promising practices, especially in rural and suburban areas. Free transportation is a huge part of getting people to actually use care when they need to use in-person care. So Mr. Jones gets linked to free transportation to health center via van service. He also gets appointment reminders via facility mobile application and text. So when he has an appointment, he gets bim, bam, boom. He's not going to forget it because he has multiple reminders, which, to be clear, I need when I have to go get my dental service. So I think Mr. Jones is going to need it as well. Neighborhood and built environment. So the CHW is able to get utilities vouchers provided from a local community-based organization, and social worker contracts utilities for discontinuation support. So social workers get on the phone and talk to these companies because you can get discontinuation support. But those of you who use medical legal partnerships, and if you don't, I'll have some resources for you. If you have a medical legal person, a paralegal, or an attorney that works for your center, getting them on the phone, it makes it a lot easier for that to get done. These are professionals that know how to deal with this. More on that very soon. Next slide, please. Social and community context, a local veteran support group. So for combat veterans who've experienced extreme violence, extreme deprivation from resources, difficult physical environments, being in the military is tough. And for people who have been deployed and have experienced head injuries, have serious mental health issues because of what they've experienced, being able to talk to other veterans is a really important part of care. So local veteran support groups are really important, and you happen to have one in your community. So you connect him to it. You connect him to tobacco cessation literature and research pamphlets, regular bi-monthly tobacco cessation check-ins. This patient's going to be speaking with the CHW twice a month. Economic stability. Training and support services through the facility's Job Plus site. Job Plus is a HUD program, and for those of you in the bottom left who would be either have one or interested in applying for the grant, it's a great opportunity to bring more resources into your PHA or health center via Jobs Plus funding. And what it essentially does is give people social support and economic support during the job search. And a veterans peer support group at the local church. And by peer support, I mean, there are a variety of organizations throughout the country that offer economic support to veterans. For those of you who are anywhere in the country, look to see if there's a local group that'd be interested in partnering you, because I guarantee you there might be something that you don't know about that's out there. Supporting veterans is very complex because these are often patients that have really detailed behavioral and mental health issues and are just dealing with a lot through their transition. veterans health groups are really important ways of helping with that transition. Next slide, please. So we have this patient who we've now seen him in a couple of different contexts. We have seen Mr. Jones in the exam room. We have done a detailed physical and clinical exam with him, and he is now seeing a CHW via telehealth regularly to discuss his social support and his tobacco use disorder. So, and these are sort of all the resources. Rarely do you have really so much to give to a patient, but the case was designed to sort of reflect as much of the diversity of what your program offering would be as possible. So I have a question for all of you guys, and this will be another 2-minute question. How could telehealth, excuse the typo, how could telehealth be utilized at your institution to support Mr. Jones through his TUD recovery? How are you all going to do this? If you could take 2 minutes and please put in your thoughts on how you would do this, how your FQHC or organization would do this, or if you think anything was a little off on my case and you do something differently, please let me know. And we will take, 2 minutes, and that timer is on. Looking forward to seeing your responses. Thank you. All right, Fide, we're cutting it close, so let's take a quick look here. Sorry to put it on you guys here, but let's take a couple of minutes to go over this, and then I'm going to give you guys some resources that I think are really important. So Fide, could you pick two, starting with one?
Yeah. So we did get a response by Princess Bettis. Telehealth may be used to assist Mr. Jones with various treatment options, including CBT, and provide him with access to local cessation groups since he does not have access to a car.
You know what, Fide, let's start with this. Do any of our sharers, would they like to share verbally? If you could please raise your hand. If not, we'll read through them.
Mm-hmm.
So you can go ahead and read through those.
Read the next one. Okay. And then next we have a response by Karina. I have seen success when having a CHW follow-up regular with people suffering from a variety of chronic conditions, and I think this might work for this as well.
Mm-hmm.
Yep.
And I think we had a response from Deborah there as well.
Deborah. Yes, that is correct. Used to keep Mr. Jones connected to his healthcare team and allow him to feel heard on his level of comfort.
Yeah, you guys get this, and there's a couple of things I want to re-emphasize here in our very well thought out answers. One, keeping Mr. Jones connected to his care team. He is dealing with significant chronic diseases, behavioral health issues that are very hard to deal with, and this tobacco use disorder. This is a person who needs regular support and needs continuity of care, and that's really the important emphasis here. Two, the telehealth Yeah, so CBT and providing them access to local cessation groups are really important. CBT is something I did not put in my case study, which is something that's absolutely needed here. This is the patient that needs behavioral health care regularly and behavioral health care that meets his needs. Thank you for that. And Karina, your point with the chronic conditions and the need for extensive social support is also well understood as well. I have also seen that success, and the more complex the patient, the more of that they need, because there's just a lot of things that need to be understood separately, treated separately in order for the whole patient to feel better. So I appreciate that. I appreciate all of your answers and for the excellent care you're giving to your communities. Let's go through a couple of resources before we sign off. What is a medical legal partnership? So these, my friends over at the National Center for Medical Legal Partnership do exceptional work supporting our FQHCs. They are also an NTAP. They are very nice and would love to talk to you about setting up a medical legal partnership at your organization or supporting your current medical legal partnership. For patients who are dealing with housing issues, evictions, who are dealing with predatory loans, who are dealing with utility companies that are shutting off their stuff or being aggressive. Having a medical legal partnership is a great way to support your patients. So if you go to the bottom left, you can go to the Health Center MLP Toolkit and help walk you through how to make or strengthen a MLP or support an existing MLP. And I would encourage you guys to reach out to the National Center for Medical Legal Partnership if it's something you're thinking about doing. I'd be happy to connect if anyone wants to connect. Next, please. And this is kind of some fun reading for those of you who find these subjects interesting. Please shoot me a text. Please shoot me a text if you'd like to connect on. The impact of wars on drugs on STOH, therapeutic jurisprudence does not work. And in our communities, there is a really disproportionate burden of incarceration on healthcare. And here is a great paper for understanding that on an epidemiological and social perspective from the STOH perspective as well. Next one, please. Final one. And a couple of fun updates for you guys. So updates requiring the buprenorphine prescribing. In many health centers, there's a real bottleneck in being able to have MAT providers and so forth that can provide the drugs necessary for opioid use disorder. The SAMHSA recently changed its recommendations regarding the prescription of buprenorphine, and it's much more open and able for non-certified providers to be able to send it. So if you go to the bottom left, the MAT Act, it'll tell you a bit about how that recent legislation will affect your practice. I recommend reading it. If you're not a provider, if you are a provider of MAT, you probably know about it already, and I'm really excited for you. Next slide, please. And finally, a new funding opportunity for those of you who are in rural areas and your health center has any use of emergency services. So SAMHSA is giving up to $200,000 a year for a program to recruit and train EMS personnel in rural areas with a focus on addressing substance use disorder. Amazing opportunity to put a grant in for something that would certainly help. Being able to have emergency medical professionals at your center who can respond to substance use disorder is a great service to have, especially when there's good funding behind it. So link down to the funding opportunity. The grants are due by March 20th. If you want some help, shoot me an email. I'd be happy to help. I think that's it. Fide, do you have any wrap-up slides? Oh, yeah. So for those of you who are interested in the use of STOH screeners, I've got a couple of protocols in here for when in the clinical continuum you could put those. If you want some advice or consulting with that, please let me know. I'll stop now.
Okay. Thank you so much, Kevin, and thank you everyone for providing your responses and engaging with us today on the webinar. So this is just a reminder to everyone to please complete our post-evaluation survey, which will pop up on your screen right after the session. And we'll really greatly appreciate your feedback. And also, this is our contact information. Again, if you would like to get connected also with the Medical Legal Partnership Connections, you can contact Kevin at kevin.lombardi@mgt.com, or you can also contact me and I will make sure to refer any questions that you may have at fida@mgt.com. And thank you all today. And we look forward to seeing you in our future TTA sessions. Thank you so much.
Thank you all for your service to your community. It's always a pleasure to talk with and learn from you guys, and looking forward to seeing you soon. Bye. Don't be shy. Bye.
Bye.